Hello and welcome to the HIV Health Improvement Affinity Group Kickoff Webinar. This is Deirdre Stockman from the Center for Medicaid and CHIP Services at CMS, and I'll be moderating today's call. We have a robust agenda full of presentations from esteemed guests and state leaders, and time for question, answer, and discussion a little bit later in the day. So we're really looking forward to the next hour and a half together. Next slide. As you all know, the purpose of the HIV Health Improvement Affinity Group is to support state efforts to improve care for and improve viral load suppression among people living with HIV and AIDS through technical assistance and state-to-state peer exchange. Specifically called for in the National HIV/AIDS Strategy Federal Action Plan, this affinity group aims to encourage new or additional collaborations between HIV/AIDS programs and state Medicaid programs to achieve these goals. Next slide. Before we get started, I have just a couple of notes on logistics. I believe your lines are muted, but for the speakers on the line, just a reminder to keep your line muted when you are not speaking and not to put us on hold so that we don't hear any lovely hold music that your agency may have. For everybody participating, please use the chat box on your screen to ask questions or leave comments at any point during the webinar. And as I noted, we will have time for moderated question and answer a little bit later in the call at a few different points. There's a note here that the chat box will not be seen if you're in full screen mode. So if you want to enter a chat and you're not seeing the chat box, make sure to exit out of the full screen mode to leave a question or comment. And next slide. I would like to introduce our first speaker, Dr. Amy Lansky, Director of the White House Office on National AIDS Policy. Amy,
Great. Thank you so much, Deirdre, and thanks to everyone for being here today and for your interest in developing this affinity group. I think it's really exciting to be at the kickoff for your activities today. I want to talk a little bit about the National HIV/AIDS Strategy. And as Dr. Stockman said, the affinity group came out of one of our actions. And so just want to be sure that folks are grounded in the strategy as you begin your work. So our National HIV/AIDS Strategy was actually first released in 2010, and it was the first comprehensive strategy for the United States. And the strategy was updated in 2015 to take us through 2020, and I'll be talking mostly about our updated strategy today. So our updated strategy is actually a family of 5 documents. We have our strategy in both English and Spanish. We have an indicator supplement, the Federal Action Plan, and a Community Action Plan framework. And I'll touch on these as I go through my talk today. If I could have the next slide, please. So why did we need to update this strategy? Well, this is where we found ourselves in 2015, is that there had been many changes in the science, policy, and programmatic landscape for HIV prevention and care. We had the Affordable Care Act passed, which really transformed healthcare access. We focused on the HIV care continuum, which we'll be talking about more today. HIV testing and treatment had more formal recommendations for routine testing and treatment for all people with HIV. Our prevention toolkit expanded to include pre-exposure prophylaxis, or PrEP, and treatment as prevention. And of course, research continued to unlock new knowledge and tools, including long-acting antiretroviral treatments, work towards an HIV cure, and an HIV vaccine. Next slide, please. Our goals of the strategy remain the same, however: reducing new HIV infections, improving access to care and health outcomes for people living with HIV, reducing disparities, and achieving a more coordinated national response. And the affinity group really comes under both Goals 2 and Goal 4. The item in the action plan is specifically listed under Goal 2, helping to strengthen the provider workforce by sharing practices within and across states. But also, as we will see today, there's a good bit of collaboration across federal agencies and across your organizations at the state level as well. Next slide, please. So there are 4 key areas of critical focus in our updated strategy, and these are the key activities that really will take us towards achieving the goals of the strategy. And a lot of the activities here are related to what's proposed in your projects in the continuum of care, HIV testing and linkage to care, which will enable people to access HIV treatment early, PrEP services for those who are HIV negative and at substantial risk, support for people living with HIV to remain engaged in care and adherent to their treatment, and universal viral suppression among people living with HIV. And it really is these steps along the continuum to help get us towards universal viral suppression that are the focus for some of our activities within this affinity group. Next slide, please. So we talked a little bit about the HIV care continuum, and to the right in 2013 we had an executive order that established the Care Continuum Initiative. But can you hit the next button? I think there's some animation on. Nope, the animation didn't work. Can you go back? Thanks. So what happened with our order to implement the strategy is that we brought together the Care Continuum Initiative, our work on the intersection of HIV and violence against women and girls, and we updated the 2010 strategy. So all of those came together into our new strategy. And I'd just like to point that out, that our work from the HIV Care Continuum Initiative is ongoing, and it's included as part of the strategy. It's not a separate activity that we do. Next slide, please. Our order to implement the strategy also named 10 federal departments and agencies to implement the strategy. And these include 10 agencies with HHS as one of those, and of course there's multiple agencies and divisions within HHS participating. But it takes a lot of agencies to do the very broad work of the strategy, and each of the ones shown here has a piece of the implementation. Next slide, please. With our updated strategy, we also created some new indicators to be able to monitor our progress towards the goals of the strategy by measuring certain indicators on an annual basis. And this slide is depicting where we are with reaching our annual targets with our most recent data. And those data show that overall progress is being made in the fight against HIV. We can see that there's progress in each of the 3 goals shown here. And so we're looking to increase some of that progress, because the data also show that we're not seeing progress on some indicators. And disparities are actually widening for certain groups, where you can see the X's for gay and bisexual men, for people living in the South, and those who are homeless as well. And detailed information about all of our indicators are available in the indicator supplement, which is one of the 5 documents for our updated strategy. Next slide, please. Also this year, we're adding 3 new indicators to better monitor progress towards the goals of the strategy, and these include PrEP use, HIV stigma and HIV among transgender persons. And we'll be releasing these new indicators in December of this year, but I will point out that our indicator for transgender persons is specifically increasing viral suppression in that group. Next slide, please. So since it's been a year or so since we released the updated strategy, my office has been focusing our time in hearing about how people are implementing the strategy, and that includes at the federal level as well as at the state level and in communities. So we've held a number of meetings with various community groups, networks of people living with HIV, those who've been implementing PrEP, transgender advocates. We've had a number of stakeholder meetings with HIV care providers, educators, and policy advocates, and also have hosted some listening sessions as well to hear about how people are implementing the strategy. Next slide. But I will say that we are doing this because as a guiding document, the strategy really is a national plan and not just a federal plan. And so we're working broadly to hear and understand how people are implementing the strategy across the nation. And as we indicate in the strategy itself, the goals can only be achieved by engagement at all levels and across all sectors. And everyone is needed to put our strategy into action and end the HIV epidemic. Now, I've been talking a lot about concepts and policies and national work and want to take just a few minutes or less than a few minutes to talk a little bit about the people. So if I could have the next slide. In the United States, we have 1.2 million people living with HIV, and about 87% of those know their serostatus. And I think for our purposes today, that indicates the people who should be in care. And we also know that about half of all people living with HIV are covered by Medicaid. And so the work you're doing with this affinity group is really critical. Next slide, I'm going to skip, and if you'll go to the next one. So just to wrap up, I do want to take the opportunity to wish you well in the endeavors going forward, and I look forward to hearing about your accomplishments and being able to tweet about them and also to be able to post your activities on our White House website and through AIDS.gov. Thank you very much.
Thank you very much, Dr. Lansky. Next, I would like to welcome Acting Assistant Secretary for Health at the Department of Health and Human Services, Dr. Karen DeSalvo.
Well, thank you, and good afternoon, everybody, and welcome to the webinar. It's really a great pleasure to be here to help kick off the HIV Health Improvement Affinity Group. I hope you all can see from the level of participation and collaboration across HHS how important this is to all of us, whether CMS, CDC, HRSA, and the Office of HIV/AIDS and Infectious Disease Policy, and which is here in my office at OASH, led by Dr. Rich Volitsky. All of us are deeply committed to this project and to supporting your success. Another sign of how important this project is to us and our partnership with the National Academy of State and Health Policy is their presence. They bring a wealth of experience and expertise in health policy and practice, and we're all very pleased they will be working to support the Affinity Group. The importance of the Affinity Group is also reflected in the interest that the White House has shown, and I want to thank Dr. Lansky for her ongoing support and for her remarks today that remind us of how the Affinity Group can help achieve the goals of the President's National HIV/AIDS strategy. The Affinity Group is important to us, but I know that it is also critically important to you, to your states, and to the people that you serve. Thank you all for making time to be here today and for joining in this groundbreaking effort. When I first heard about the Affinity Group, I was excited because its potential to create new partnerships that would lead to innovative approaches, and the positive impact I think it could have on health in participating states is exciting. The teams on the webinar today represent the 19 states that have joined the Affinity Group. This response makes this the largest of any of the other affinity groups that CMS has created since the first one began in 2015. I do feel a very special sense of pride that my home state of Louisiana is a part of the group and that their work is being featured on today's call. The 19 states in the Affinity Group account for more than half, 55%, of people living with an HIV diagnosis in the United States. That is more than 500,000 people. We know that far too many of them are not receiving regular HIV medical care and have viral loads that are not suppressed, which puts them at risk for serious health problems and increases the risk of HIV transmission. Just over half of people diagnosed with HIV are virally suppressed. That means that almost half are not. This is an unacceptable percentage of people who are not receiving effective medical treatment. And we know that without treatment, most would progress to AIDS, and that could eventually lead to death. But these deaths are preventable. With the effective treatments we have today, nearly everyone can achieve viral suppression if they receive the right support. And as a result, they will require fewer medical visits, fewer emergency room visits, and fewer hospitalizations. Historically, the biggest challenges have been access to affordable health care, but thanks to the Affordable Care Act, 20 million people now have health insurance. It's also eliminated exclusions for pre-existing conditions, and this makes it possible for people living with HIV and those with other serious illnesses to get health insurance and access needed medical care. But we know we have challenges in coordinating care across systems. More than half of people living with HIV get services from the Ryan White program, and many of these clients receive at least some of their HIV medical care through Medicaid. Those that do may also receive supportive services such as case management, mental health services, or other services through Ryan White. And this makes coordination between Medicaid and Ryan White programs critically important, something I learned firsthand as Health Commissioner in New Orleans running Ryan White programs. Yet another challenge is that too many people who have access to care are dropping out of care. And when that happens, they can fall through the cracks. In many places around the country, healthcare systems do not have it in their mission or responsibility to re-engage patients who do not show up for appointments. Our healthcare systems are not always easy to navigate, and patients often face multiple challenges that make it difficult for them to stay in care. And as a result, we are missing important opportunities to help address those challenges, including areas like housing and food instability, transportation, childcare, substance use, and mental health problems that can make it more difficult for people to stay in care and stay healthy. As many of you may know, I see work to address these underlying issues, these social determinants of health, as an essential part of the public health, a new era called Public Health 3.0 that upgrades public health practice to emphasize cross-sectoral environmental, policy, and systems-level actions that address all the determinants of health and advance health equity. If we are to make further gains, we need to do better working across silos, sectors, and funding streams to impact all the determinants, including the social determinants of health that are driving morbidity and mortality. We've made great strides in our ability to use data across different systems to improve the health of people living with HIV. And some states have been doing this for a while now, but others have only recently developed the ability to monitor all CD4 and viral load results and to identify people who have dropped out of care or who have not achieved viral suppression. Other states still do not have systems fully up and running. But states are learning more every day on how to use data from Medicaid, healthcare systems, Ryan White, HIV surveillance, and other sources so that we can work more efficiently and collaboratively across systems to provide better HIV care to people living with HIV and help more people achieve viral suppression. It's exciting that some of the states that have been leading the way on these efforts are a part of this affinity group. And by joining in this network, I'm sure you will help all of us learn more about your best practices and how to overcome challenges to providing the best care. We are committed to bringing our knowledge and resources at the federal level to support all of you as best we can. And so now before I close, I just want to say a few words about the progress that we have made on the prevention end. We have known for some time that HIV treatment reduces the risk of HIV transmission because it brings down levels of HIV in the body. and we've had incredible success in using HIV treatment to prevent perinatal transmission. Since 1994, when researchers proved that giving HIV medication to pregnant women and their newborns reduced the risk of mother-to-child transmission, HIV infections through perinatal transmission have declined by more than 90%. We now have an opportunity to drive down sexually transmitted HIV infections in the same way. Data from the 4-year follow-up of the HPTN 052 that were published in July show that early HIV treatment reduced transmission by 93% in couples in which one person was HIV positive and the other was not. What was even more remarkable was that the researchers could not link any of the infections that occurred to someone whose viral load was suppressed. It does not mean that it will never happen, but it does mean that the odds that someone who is virally suppressed will transmit HIV are very, very low. This has tremendous implications for preventing new HIV infections in the U.S. and around the world. CDC researchers have modeled what would happen if we could increase the percentage of people diagnosed with HIV who are virally suppressed to 80%, which is the goal of the National HIV/AIDS Strategy. If we were able to achieve that goal by 2020, more than 160,000 new HIV infections could be averted. Improving viral suppression is without a doubt the single most important thing we can do now to save lives and prevent new HIV infections in the U.S. We are truly at a watershed moment in the history of the HIV epidemic. The work that we do now has the potential to put us on course to ending new HIV infections and realizing the vision of an AIDS-free generation. You have my support, the support of my office, and I am expecting really great things from the work of this Affinity group and from all of you. Thank you so much for what you do every day, for your passion, for your commitment. I hope that the webinar gets all of you off to a good start on this great journey together. Thank you.
Thank you, Dr. DeSalvo. We appreciate you taking the time to join us today and provide your remarks. Our next speaker is Dr. Andrei Ostrovsky, who will provide us with an overview of the priorities and perspectives from the Center for Medicaid and CHIP Services at the Centers for Medicare and Medicaid Services, or CMS. Dr. Ostrovsky joined the Center for Medicaid and CHIP Services recently as our Chief Medical Officer.
Great, thank you so much, and thanks everyone for having me here. The HIV Health Improvement Affinity Group is a key example of this strong and growing collaboration between public health and Medicaid. And this collaboration is necessary to improve health outcomes for our beneficiaries and for all Americans. The Center for Medicaid and CHIP Services, CMCS, where I work, is pleased to be partnering with the White House, Office of the Assistant Secretary for Health, and our sister agencies, CDC and HRSA, in this very important effort. The Medicaid Prevention Learning Network provides an opportunity for state Medicaid programs, along with their public health partners, to engage in state-to-state learning and receive enhanced technical assistance to improve delivery of preventative health care in Medicaid and CHIP. In 2015, CMS began forming affinity groups to focus on prevention topics of common interest to states. The HIV Health Improvement Affinity Group is the fourth group to be launched by CMCS. Other affinity groups include antipsychotic drug use in children, or ADC, diabetes prevention and management, and tobacco cessation. While each of these groups has relied on partnerships with our sister federal agencies and expertise they bring on these issues, this is the first affinity group to be jointly launched with the CDC and HRSA. As you know, the goal of this affinity group is to support state efforts and partnerships to improve care and health outcomes for people living with HIV and AIDS. And as Dr. DeSalvo mentioned, in addition to improving health for those individuals, high-quality care and suppressing viral load are keys to preventing further transmission of the disease. Because viral load suppression is an indicator of access to and quality of care, as well as an indicator of prevention, we've included the measure in our core set of adult health care quality measures for Medicaid, commonly called the Adult Core Set. We're so pleased so many states are interested in putting in place the data agreements needed to collect and report that measure, and I really want to underscore that. We're really excited about this. In addition to establishing the data linkages necessary to generate the viral load measures, I'm pleased to see that so many states in this group are already thinking about how to use those data and this cross-sector collaboration to get more Medicaid and CHIP beneficiaries into regular care. It's exciting to see states recognize that the purpose and importance of collecting and reporting the viral load measure or any of our core set measures is to identify opportunities for improvement and use these metrics to drive further improvements in care. This goes along with the adage in performance improvement of it's hard to improve something if you can't measure it. And with your help, with the state's reporting, we can all measure and further suppress viral loads across the U.S. Through this affinity group, we're excited to support states in building out the infrastructure they will need to be able to measure and report on viral loads at a state level. And there are a lot of exciting state innovations that are emerging, and I just want to share one that's particularly promising. The Medicaid Health Home State Plan option, as authorized by the Affordable Care Act, may be particularly effective as a model for coordinating and delivering the medical care, behavioral health care, and community-based social services and supports that persons living with HIV need to successfully navigate the HIV care coordination and care continuum and achieve viral suppression. Many of the services that define the health home model, including comprehensive care management, care coordination, and health promotion, individual and family support, and referral to community and social supports, to underscore Dr. DeSalvo's point. Many of these are recommended strategies for improving engagement in care among people living with HIV. So I want to thank everyone for your participation. I'm really excited to be supportive of this work and eager to learn on this webinar. Thanks, everyone.
Thank you, Dr. Ostrowski, and again to Dr. DeSalvo and Dr. Lansky for taking time to join us today. Before we move into the state presentation of the webinar, we'd like to do a roll call of the states on the line. We wanted to do this verbally, but we know that many of you are tuned into the computer audio. So we're going to do it in two ways. We're going to ask you to chat in your name and state into the chat box so we have a nice document of who has joined us today. The computer is telling me that we have 142 participants on the line today, so that is a lot. And while you take the time to chat in your name and state, I'm just going to read through the states that are participating because I'm not sure if everyone has the map in front of you, but if you need a refresher on which states those are that are in dark blue, I'll read through them briefly while you chat in your names. So we have Alaska, California, Connecticut, Georgia, Illinois, Iowa, Louisiana, Maryland, Massachusetts, Michigan, Mississippi, Nevada, New Hampshire, New York, North Carolina, Rhode Island, Virginia, Washington, and Wisconsin. As Dr. DeSalvo mentioned, this is by far the largest of the affinity groups that the Center for Medicaid and CHIP Services has launched, in this case fortunately co-launched with CDC and HRSA, as well as with the support of NASHP to work with such a great group representing a large portion of the country. So next we have two states that will present on some of their experiences to date with data linkage and viral load reporting. After both of these states present, Lieutenant Commander Kathleen Davis will facilitate a question and answer portion. If you have questions during the presentation, again, please put them into the chat box and we'll read them out when we come to the question and answer period, but feel free to ask them at any point. We'll start with a presentation from Louisiana and Dr. Shreeram Koi. I don't have your title, Dr. Koi. You'll have to tell us what it is.
Hi, this is Shreeram Koi from Louisiana. I'm the Chief Medical Officer for Louisiana Medicaid, and I wanted to say thank you so much for the opportunity for us to participate. This is such an honor. Thank you. So,
thanks. Go ahead.
Fantastic. So I'm going to talk about the great collaboration that's been going on between Louisiana Medicaid and the Louisiana Office of Public Health, which are all in the same family. Together we're part of our Louisiana Department of Health. So the goals of what I'm going to talk about in this project is describe our work with our focus on HIV viral load suppression. As Dr. DeSalvo mentioned, that improving viral load suppression is really the single most important thing that we can target as we're combating this issue. The outcome of our project was the development of collaboration between Louisiana Medicaid and Louisiana Office of Public Health. And what did we find? We found that through collaboration with our two sister agencies, we were able to achieve a 79% viral suppression of all those patients who are in care. And this really was a result of data sharing between Medicaid and the Office of Public Health, as well as individual level data that was provided back to each of our what we call Healthy Louisiana plans, which are our managed care organizations for use with their clients, and also the addition of innovative work with incentivized performance metrics. So our key stakeholders in our group included Louisiana Medicaid, Louisiana Office of Public Health, our managed care organizations, which are the predominant group for our Medicaid providers, and our providers and our patients. So this really sums up the majority of our talk, this graph here. What it shows is that in 2015, we had more than 19,000 people in Louisiana who were living with HIV. And of those, 72%, about nearly 14,000 were in HIV care. Among those who were in care, 79% of them, 10,600, were virally suppressed. So I'm going to go down to the next slide. So how did we accomplish this? It's really all through a data sharing agreement and the collaboration between the two sister organizations. So looking back historically, a few Office of Public Health programs had negotiated data sharing agreements with Louisiana Medicaid, but there are many programs that didn't really have any access to this Medicaid data, which was really the key to be able to move this forward. However, there was a change in our leadership in Medicaid, and that resulted in a change in the environment to really create an environment of collaboration. And we were then able to establish an agency-wide data sharing agreement. This is supported tremendously by Medicaid as well as our Office of Public Health Assistant Secretary. It took us about 6 months to achieve this process. And we signed our data sharing agreement in February 2014, where all users had to complete this data sharing agreement. So the measure that we looked at was HIV viral load suppression. And this was eventually used in what we call performance improvement projects and then in our incentivized performance metrics. Our managed care plans in Louisiana, we call them Healthy Louisiana plans, and they have incentivized-based performance metrics where the plans need to meet a certain criteria, a certain target rate. If they don't meet this, then they're penalized about $250,000 for each metric that they don't meet. In 2014, we made this a new metric, and if the plans were able to meet the viral load suppression measure with a target rate of 54%, then they were not penalized with $250,000. So how are we able to add this viral load incentivized-based measure? It really was dependent on having team collaboration between Medicaid and OPH. We had a quality champion here at Medicaid. We had meetings, many meetings to discuss joint projects. We had support from the leadership of both Medicaid and OPH. And it originally started as what we call a performance improvement project, which then evolved into a incentivized-based measure that we were able to hold plans, managed care plans, accountable to. So it really is the child of collaboration between the sister organizations. So what did we do? We looked at Louisiana HIV surveillance data. Beginning in 1993, we had HIV reporting. And since 1999, all CD4 and viral load values have been reportable. We have both public and private labs reporting, except, of course, the VA system. And we found that we had about 90% of the labs reporting electronically and reporting daily for the larger laboratories. Then we conducted a match between the data from Medicaid and a match with the data from OPH starting in 2014. Medicaid was able to provide OPH with all the recipients who had an HIV-related diagnosis code, because so much of our data is claims levels data, and then determine whether the plans met the viral suppression target of 54%. We conducted a second match in January, and again, Medicaid provided all recipients who were enrolled as of December 2014. And this diagram really shows how the data was put together. So we had all patients who were enrolled in Medicaid, which at that time was about 1.5 million lives. And we looked at among Medicaid patients who had an HIV claim, and then looked at to see if that matched with OPH's database. And sometimes there were no matches, but in the majority, about 94%, there was a match with the OPH database. Then we looked at their viral load suppression. There are also patients in Medicaid who had no HIV claim data, but there was a match for those patients in the OPH database, so we were able to capture an additional nearly 3,000 patients through that. Then we looked at the patients who had no HIV claim. Oh, that's the same slide. So by doing this matching process, we're able to do quarterly matches between the Medicaid claims data and the OPH HIV surveillance data. And that really, I think, is the key to the success that we've had, is the collaboration with our OPH team and the Medicaid team in bringing our data together, because clearly if you didn't, you'd see there'd be many gaps in the data. The variables that were looked at by OPH then were, was the client virally suppressed with a viral load less than 200, and was there a test that was done within 12-month period? And also, was the client confirmed to be HIV positive in the database? So what we found, so we have 5 managed care plans, and we have a fee-for-service plan here in Louisiana. And what we found was that all of them exceeded the target of 54%. So rather than resting on our laurels, what that taught us is that we can move the ante up and increase our target rate to a much more aggressive rate as we try to keep working to achieve better results. And all this work is really the result of collaboration between Louisiana Medicaid and OPH. And if you all have any questions, we have our email addresses up here from both Medicaid and from the Office of Public Health with Deanne Gruber and Debbie Wendell, who have been an integral part of this. Thank you so much.
Thank you, Dr. Coy. And again, reminder to folks to please type in questions into the chat box, and we'll have a Q&A after our next state presentation. Next up, we have Eileen McRae and Mary Rutan from Wisconsin.
All right, well, thank you. Hello to everybody. My name is Mary Rutan, and I am the Ryan White Coordinator for the Wisconsin AIDS HIV program. Today, Eileen McRae and I will give a brief overview of the relationship between the Wisconsin Medicaid and public health programs. Next slide, please. During our presentation, we will highlight our previous collaborations, the items that we will be focusing on as part of this initiative, what we plan to achieve through participation in the effort, also what we plan to have continue to happen after the Affinity group is completed, and what we want to learn from all of our fellow participants during this initiative. Next slide, please. So Wisconsin is fortunate that both the Division of Healthcare Access and Accountability, which houses the Medicaid program, and the Division of Public Health, which houses the AIDS/HIV program, are co-located within the Department of Health Services, and in fact, we're located within the same building. So this has really helped to facilitate our close working relationship. And then in addition to just the logistics of the relationship, we're fortunate that the leadership in both programs is committed to preventing HIV infection and helping people living with HIV to achieve viral suppression. And so far we have had successful collaborations. The AIDS/HIV program has worked with the Medicaid program to ensure that people living with HIV have access to and coverage of antiretrovirals through inclusion of those medications on the preferred drug list. We also partnered in developing and implementing an HIV medical home. And the Medicaid program on a quarterly basis shares aggregate data related to service utilization and the associated costs which is really important for helping us to understand the full scope of care services accessed by persons living with HIV. We have really good data on our Ryan White recipients, but it's important to bring in the Medicaid data as well. Next slide, please. So to date, our projects have involved aggregate level data, and as I said, that's really important to help us better understand overall service utilization and expenditures, but we want to start drilling down and targeting our efforts to the individual level. So with that as our goal, we have identified 2 projects to work on as part of the Affinity Group effort. First of all, we are looking to enhance the evaluation of the HIV medical home. We want to verify that it is making a positive impact on health outcomes at the individual level. And then we also want to work with improving the positive health outcomes for pregnant women and their babies by promoting HIV testing for all pregnant women. Next slide, please. We selected these projects because they are priority areas for both programs, but neither program has the complete data necessary to conduct a comprehensive evaluation. The Medicaid program has access to claims data, and they can determine from that if HIV testing has been done, if follow-up lab work has been conducted, but they do not have access to see what the results of those lab tests are, because that information is housed in the AIDS HIV program. And likewise, we can see all of the lab values, but we can't always match it back to individuals and to specific claims. So through the Affinity Group, we want to ensure that both of our programs have access to complete and meaningful data. So with that, with our HIV medical home, at the aggregate level, we've been able to examine prescription fills, hospitalization rates, and emergency department utilization for the participants, but we haven't been able to examine the impact on their individual viral loads and CD4 counts. And these lab data are obviously very important to determine the initiative's impact at the individual level to ensure that people are achieving viral suppression. With pregnant women, healthy birth outcomes involve both the mother and the baby, and so we want to ensure that all pregnant women receive an HIV test, and that any mother who does test positive is immediately connected to the proper health care to help her achieve viral suppression and prevent transmission to her baby. Next slide, please. So then beyond these 2 initiatives, we want to develop an ongoing client-level data sharing program to ensure that both programs have complete and accurate surveillance data, that high-risk populations are participating in HIV testing. We also want to ensure that individuals who have fallen out of care are identified and that outreach is conducted to re-engage these individuals in medical care. And finally, we also want to ensure that individuals who are at risk at falling out of care, and we would define these as individuals who have had a history of missing appointments or who are on antiretroviral treatment but still have a detectable viral load. So we want to identify those individuals and do appropriate interventions to ensure that they are actively staying engaged in care. Next slide. And so we do believe that we can do all of these things, but during this initiative, we would appreciate hearing from all of our partners and learning how you have been able to successfully share client-level data.
Right. We were excited with Louisiana sharing because what you just presented is where we're trying to get to. This is Eileen McRae. I'm the AIDS HIV policy analyst with the Medicaid program.
And next slide with that. There is Eileen and my contact information. If anybody has questions about any collaborations that we've done previously or has helpful hints, we would welcome any input from you. Thank you.
Thank you, Ms. Ritton and Ms. McRae, for your presentation. So we will now take some time for some questions from the state. Please type your question into the chat box and we'll try to answer as many as possible, but I'll be honest, it's not popping right now, so we have plenty of time for questions. We did have one about whether or not the slides will be made available, and the answer is yes. We hope to have those slides out to you within a week. They will be coming from our NASHP partners. And as well, we're putting together a link for the webinar, a recording, so for people who are not able to attend today, they'll have access to the recording. So I'm looking at the chat box, anticipating questions. But in the meantime, do we have any questions from the room? Sir.
Yes, I have a question.
Announce who you are, please.
Oh, sure. Stephen Young with the HIV/AIDS Bureau. I have a question for Dr. Coy, if she's still on the line. When you mentioned that you share the data back with your local managed care plans, I was wondering if you had an idea of the extent to which providers funded by the Ryan White program, all parts, were participating in those plans, and whether you could draw any connection to the receipt of those funds with the metrics.
That is a great question. This is Dr. Coy here. I have our wonderful colleague, Deanne Gruber, who is with our OPH group, and Deanne's going to take a stab at that.
Hi, Steve. This is Deanne. And you know, at this point, actually, we do know that we have several Ryan White providers who are also Medicaid providers, that they are in those plans. It's a really good question that we're going back to do some further analyses, you know, really provider by provider to identify, you know, individual practices or clinics that are serving a significant number of individuals. So I don't have a straightforward answer for you today, but it is something that we're looking at in the data.
Great, thank you.
Thank you. We have a question from Wayne Turner. What is an HIV claim? How does Louisiana identify individuals who obtain HIV meds outside the Medicaid managed care system, for example, ADAP, and how does the data account for churning?
Wayne, that's a great question. This is Dr. Coy. In terms of an HIV claim for Medicaid, that's looking at diagnosis codes such as, you know, ICD-9 back then, now ICD-10. I don't know about churning. Can you explain what you mean by churning?
It usually means moving from health plan to health plan or moving in and out of Medicaid given changes in eligibility status.
That is one of the limitations that I don't really know that we can account very well for, but maybe Debbie can add on anything else. Do you have anything further to add, Debbie?
Yeah, I was just going to add that we only included people who were enrolled for at least 11 of the 12 months. In Medicaid. Yeah.
So this study was looking specifically at Medicaid.
All right, thank you, ma'am. So the next question is, we welcome any suggestions, so this could be for Louisiana or Wisconsin or anybody else. We welcome any suggestions for initiating cross-programmatic data sharing, especially with respect to legal and submission of that information back to non-HIV CMS entities.
This is Dr. Coy. I think the big thing is data use agreements. That is a really, really big part, and Deanne is actually nodding her head because any kind, not just HIV data, though that certainly is very sensitive, but any of our data when we're looking at utilizing health information technology and looking at using electronic health records to better do analysis for quality improvement, it absolutely depends on having a good data use agreement. And I think we'd be happy to share what we have also. If y'all want to, my email is on the presentation. Just shoot me an email. We're happy to share our resources. Our goal is really to use the successes Louisiana's had and help other states be able to implement the same things. And I think the second part of the question is how do you get that collaboration? And it's all about just both organizations acknowledging that we have the same goal, and that's to help make the people of our state healthier. And then it's not a matter of pride or who has the credit, but just plain helping the people of Louisiana. That's how you get the collaboration.
Thank you, ma'am. Thank you for sharing that. Do we have anything else from anybody else? Okay. The next question is for Wisconsin. The agenda refers to HIV health home model. Is that an error, as comments seem to be about the medical home?
No, Wisconsin has Section 1945 health home that we worked with our public health AIDS HIV partners to implement. We also have a medical home for pregnant women, and that's not limited to women with AIDS HIV. It's just for pregnant women who are high risk factors because of any medical or non-medical. Mostly we're looking at non-medical factors. So it's both a medical home for in terms of our managed care in Southeast Wisconsin, but the 1945 health home. Hope that answers the question.
Thank you, ma'am. It does. So a question for Louisiana. Was all the Medicaid enrollee information shared with OPH or only data for those Medicaid patients with HIV codes?
So for Anshu, that's a great question, and we started with all 1.5 million lives, and that was shared, and then they were able to extract from that the ones that had the HIV diagnosis code, so all of the Medicaid population enrollees.
Great, thank you. I'm going to hold on a couple seconds to see if there's more questions coming through. Okay, we have another question. So NASDAQ's white paper financing HIV prevention services includes a case study featuring this collaboration in Louisiana. The case study describes the process of forming the collaboration. So that was more of a statement than a question. But thank you for sharing.
And this is Deirdre from CMS. I just wanted to, there was a question a little while back asking the presenter states for more advice on their data linkage process. And we wanted to assure you that there will be many more opportunities through this affinity group to get more input and advice from your peer states and others on that question. So more to come.
Okay. Again, we want to wait a couple seconds for people who might be typing. Okay, I don't see any questions right now, but what we're going to do is we'll move it on to Rachel Yelowich from NASHP to give us a little more oversight about the technical assistance that you'll be receiving or be available to you. And since we have some extra time, we can keep an eye on the chat box, and if there's more questions that pop up, we can come back on. Rachel?
Certainly. Thanks so much, Kat. Hi, everyone. I'm Rachel Yelowich with the National Academy for State Health Policy. I'm pleased to be representing my fantastic team here at NASHP, working in partnership with CMS, CDC, and HRSA to support your tremendous work. Today, I will be going over the overall structure of the technical assistance that will be offered through this affinity group. If you have questions, as Kat said, please type those into the chat box. If we have time today, which it looks like we will, we can answer those live. And Kat, if you wouldn't mind facilitating those, that would be great, and NASHP can answer those. And if we don't get to some questions today, we will go back through the chat log and review them and make sure those get answered for you all. Next slide. Great. So as we mentioned on many of the intake call, we have 19 states participating in this affinity group. Much of the technical assistance that will be provided to you all will be done so within groups in order to foster state-to-state sharing and learning. While every state team has expressed interest in sharing public health and Medicaid data and those data to evaluate outcomes and performance and inform their efforts to improve the design, delivery, and effectiveness of services for Medicaid beneficiaries living with HIV, while we all are united under that common goal, what each state team expressed as their goals for the next 12 months varied based on often their state HIV positive population's needs and previous experiences. In order to provide you all with customized technical assistance, we will split you state teams into 3 learning communities based on themes we have pulled out from your desired goals for this project and respected TA needs that you have told us about in your expression of interest forms and on the intake calls and other communications with your teams. So as you can see on the slide, those learning communities are data linkage and outcomes evaluation, data analysis and use for delivery system improvement, and provider engagement and quality improvement. We expect that all of our states may need support on topics that fall within each of these learning communities. The community labels aren't meant to be overly limiting. Rather, we try to identify natural communities or groups within the context of the broader goals stated previously in order to foster more tailored state-to-state learning, and smaller groups for is usually more conducive to discussion. So we will bring states together every other month or so for learning community-specific webinars and periodically for affinity group-wide webinars based on mutual topics of interest. Each learning community will be staffed by 2 NASHP staff, and these staff will reach out to you all in the next week or 2 to introduce themselves and to provide you with more information about the technical assistance that is to come. We will regularly be engaging you all so you can have an active voice in the learning community, technical assistance planning, and to check in on your progress on your overall goals and to make sure that your technical assistance needs are being met. As you can see on the very bottom of the slide, the other key technical assistance component of this affinity group is individualized TA. You will have access to 8 hours of individualized technical assistance, and I'll talk more about that in a minute. You can go to the next slide, please. So I will elaborate on the 3 learning communities that we have. Once again, we did try our best to separate states based on your proposed goals and anticipated technical assistance needs that we learned about through our communications with you all. So the first community, data linkage and outcomes evaluation. This group of states expressed very clear, focused desires to institute or expand currently limited data sharing activities and to then focus on analyzing data to identify targets for performance improvement. And these states, as you can see, are California, Georgia, Iowa, Maryland, North Carolina, and Wisconsin. The second community, data analysis and use for data delivery system improvement. This group of states is distinguished by generally having more robust data sharing mechanisms already in place, and for the general interest of its state teams to apply this data for action that is more systems level in orientation, such as for use with developing or expanding care coordination activities to a broader population, or engaging managed care organizations to work with the state more collaboratively on delivering various aspects of HIV care. And then the third community, provider engagement and quality improvement. This is the most varied of the 3 groups, but what the members of this group have in common is that their general focus on provider engagement and service delivery improvements, especially with respect to HIV testing and access to testing services, care coordination, and retention and engagement in care. And so the states in this group are Alaska, Connecticut, Michigan, Mississippi, Nevada, New Hampshire, and Virginia. So while we have separated you initially into these communities, if your state team is reading this and you're a little bit puzzled by your placement, or you feel that and potentially goals have changed since we last spoke and you no longer fit into this learning community, please let the learning community staff from NASHP know when they reach out to you in the next week or so, and we can talk more about that, and we can make sure that you are in the right community. Additionally, if you think that your state team has the desire and staff capacity to participate in a second learning community. So that is in one community in addition to the one that you see where your state team is listed on the screen. Please also let your Learning Collaborative NASHP staff team members know when they reach out to you, and we will do our best to accommodate all of those requests. We just want to make sure that the groups stay manageable in size for, because as I said earlier, that we are hoping to keep groups as communication and small group sharing. So we'll do our best to accommodate everyone's request if they would like to participate in a second community. You can go to the next slide. So this is just a quick timeline of the that is specific to the group technical assistance that's coming your way over the next 12 months. So in November 2016, we will have an Affinity group-wide webinar. So once again, that means all states on the call today. And that webinar is going to be focused on developing problem statements and project plans. So really focusing on how to bring together your team to think about how you will operationalize and actualize your goals and objectives throughout this 12 months, and of course how NASHP, CMS, HRSA, CDC, and all of our federal partners on the phone today can support you in doing so. So then, as you know, the December 6th and 7th, we will have an in-person meeting for a portion of for all state teams in Washington, D.C. Then also in February 2017 and April 2017, we will have learning community specific webinars. Those topics, of course, are to be determined, and you'll have, your teams will have an active opportunity to help plan those. And then in June 2017 will be another Affinity group-wide webinar, again, topic to be determined based on your expressed group needs. And then August 2017 will be a final learning community specific webinar. And I do want to emphasize that this is just for the group technical assistance. The individualized support and technical assistance from our federal partners and NASHP is available and encouraged throughout the entire 12 months of this Affinity group. And I'll talk a little bit more about individualized TA now. So as I said, state teams have access to 8 hours of individualized technical assistance. In order to make sure that NASHP receives every request and that we get you the support and assistance that you need in a timely manner, we ask that you reach out, that rather than reach out to your learning community staff, you send completed technical assistance forms detailing your request to an email that we've created specifically for this project, the HIV Technical Assistance at NASHP.org, and your request will be then taken in by NASHP staff, and a NASHP staff person will reaching back out to your state team directly to work with you on that technical assistance need. You're probably wondering what I mean by a technical assistance form. That template will be coming your way when the learning community staff reach out to you and introduce themselves in the next week or two. That form will just help us standardize all of the requests and make sure that we have enough information to be helpful when we're working directly with you on your requests. Examples of individualized technical assistance may be development of a memo about what other states have done with respect to a certain policy or rule and regulation, perhaps setting up and facilitating a conference call or webinar with a subject matter expert on a particular topic, support on rules and regulations related to, let's say, a topic that I know many folks are interested in data sharing, support and strategies for working with managed care organizations. Many of you talked about wanting to engage your managed care organizations more through this project. So those are just some examples, and we can certainly talk more with you about that in your specific learning communities and answer other questions. you will have access to robust support from federal agency experts, many of whom you heard on the phone today, as well as other subject matter experts within and external to NASHP. We are working on developing a list of subject matter experts and engaging folks that will be on call and available to talk with you as appropriate based on your request. As well as I want to emphasize the really robust knowledge of your state and your peer states. You all have a lot to share, and as appropriate, we may be connecting with states in this affinity group and asking you to share lessons learned and information on current or previous work with your peer states, because as I said, you all have a really robust experience, even particular challenges that you face, that's often helpful information, and so we may be calling on you for that. That is the end of my presentation. Now I want to thank you all for listening today, and on behalf of everyone at NASHP, we look forward to working with you over the next 12 months. If there are questions, we're happy to take those now. Okay, Kat, I'll turn it back to you.
Thank you, Rachel. I'm just checking to see if we have any questions that will be coming in. We'll wait a couple minutes. Okay, I'm not seeing any, so I'm going to, at this point, turn it over to Abigail Weil from CDC.
Yes. Hi. I think we did just get one question for Rachel. When is the November webinar?
That is a great question. We will be we will be very sensitive to your schedule, so we're starting to plan that now. Frankly, tomorrow, as soon as we get off of this webinar, and we will let you know a date for that very soon. Our plan with the learning community webinars is to work with you on scheduling and have them on a specific date and time well in advance, and your learning community leads from NASHP will talk with you about that because we know how busy everyone's calendar is. Oh, and I see another question. When is the December meeting? That meeting is December 6th and 7th in Washington, D.C. That will be for, I think, up to 3 members of each state team will be able to attend, and that will be an opportunity for robust group technical assistance with federal, state, and other national subject matter experts, as well as some small group time to work together with your peer states and to work directly in small groups with those subject matter experts.
And then there is another question from Randy Mayer. Can you say more about the in-person meeting and how that will happen? I don't think we have received anything about this yet. Rachel, maybe you guys at NASHP, I thought you had sent a save the date out perhaps, so maybe we just need to make sure that Iowa receives that.
Absolutely, Randy. We will. So what we've been doing over the last month or so is we've been collecting contact lists from each state that details every person, email and phone number, and their assistant's email and phone number that's on the team. So that way NASHP can have a complete catalog of everyone that's participating in this affinity group, and we can make sure that everyone receives all of the information. And we did send out a save the date for that in-person meeting, and we will go through directly following this webinar and make sure that everyone that we have on the contact list has that has that save the date. That said, putting a plug in, if your state has not submitted a contact list form, Kiara Corso from has been emailing you about that, and follow-up email directly following this webinar, and we look forward to receiving those from you so we can make sure that you get all the communication. Oh, and then when will we get on travel arrangements, which we will need in order to get the appropriate travel authorization? Dr. Fish, we are working on that right now. As soon as we get through this webinar today. Our focus is on the November webinar, setting up the learning communities, and moving the in-person meeting along. We're in the final stages of identifying a venue, so that information is coming soon.
And this is Abigail. I'll just mention, Dr. Fish, as well, that we understand the need for a little bit of time for preparation of travel, so we will make that a priority to hopefully get something out to all of you by the turn of the month, if not sooner, because we do understand that it takes a little while to get those authorizations in place. And I'm just looking to see if there are any additional questions at this time. Okay, I am not seeing any. So I am going to go ahead and wrap this up for everyone. My name is Abigail Weil. I'm from CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. I want to thank Rachel again for providing a very helpful overview of the technical assistance approach that NASHP and its federal partners will use to support the HIV Health Improvement Affinity Group. My job is essentially to preview further, since we've already had something of a preview, what I'll call coming attractions for the next 2 months. And as Rachel has already alluded to, our plans are for a webinar to be held in November and an in-person meeting in December. But I'd like to put those activities in a slightly broader context and give a little bit more detail about them. In the weeks immediately following this webinar, we will be disseminating a generalized template that you can use to guide your project plan. Then through the November webinar and the in-person December meeting, we'll be helping you develop those plans, from articulating your problem statements and definitions of success to determining steps you'll take and the technical assistance you'll need to achieve your state's objectives. In short, our goal is to help you map a path to realizing the very exciting and ambitious visions you've all shared with us in your EOIF and intake calls. So this really gets to November and December are about taking ideas and translating them into solid plans that can really guide your activities for the rest of the affinity group experience and beyond, really. As Wisconsin has already noted, this is one step in what we hope is a long and fruitful journey towards greater collaboration between the Medicaid and HIV programs that are participating. About the plans, the points, it's important to note, because I'm a little concerned that when I say state template plans that there's some silent groaning. Since you're muted, you can't groan out loud when I mention planning and planning templates. So I do want to stop and say, in essence, we're going to provide you a planning template, and we're going to provide you with planning assistance, including feedback on your project plan. And in fact, as you've heard from NASHP, that pattern are providing tools, technical assistance, advice, and also helping you seek advice from your peers, that's going to be the pattern for the entire project, not just this immediate stage. And we believe, or at least we hope, that our input and assistance will prove informative and helpful. But we also recognize and respect that your participation in this endeavor is voluntary. So if you don't like the template, don't use it. Same goes for any other assistance we provide. Just be sure to tell us what you do need from us. We really want to make sure that we are there to support your progress, because we've established the vision for the affinity group, but the actual project plans will be yours to be implemented in the service of your visions for improving health outcomes among Medicaid and CHIP beneficiaries living with HIV in your states. And we want to respect that, and we want to work with you to further those visions. And so I just want to conclude by saying we look forward to supporting the important work you will begin or expand as part of your involvement in the HIV Health Improvement Affinity Group Initiative. And that, I think, I don't think we have any other questions, so that will conclude the webinar.
Thank you, Abby. Thank you, Abby. That does conclude the webinar. We thank everyone for taking the time to join us today. I will add my enthusiasm to Abby's that we look forward to working with you as your ideas turn into plans and projects and action over the next several months. And we'll let you go a few minutes early unless there's anything else that I have forgotten to say. All right? I'm getting no's in the room. So thank you all. Enjoy the extra 10 minutes or so back, and we'll look forward to talking with you again soon.
Thank you.
Thanks.